Okay, so good afternoon. It's a pleasure to introduce this Terumo session dedicated mainly to the role of proximal optimization technique in the treatment of bifurcation lesions. So during this session, Bernard Chevalier will talk about the latest e-ULTIMASTER data about the role of POT in treating bifurcation lesion. Then Dejan Milasinovic will explain how POT can be so important when you treat bifurcation lesion, and what are the pitfalls when you don't do a POT. And at the end, we'll have a clinical case discussion with Tom Johnson. Three of them are on board, and Gabor, who is also on board, thank you very much, will take care of the chat discussion during this session. So maybe we can move to the first lecture with Bernard.
Mr. Chairman, dear colleagues, it's my pleasure to present today about POT data in the e-ULTIMASTER registry. This registry has been conducted in many countries. As you can see, a total number of 37,000 patients enrolled from October 2014 to June 2018. Just to remind you the situation of POT during this enrollment time, it was initially proposed by Olivier Darmon at EBC 2007. In the fifth consensus at EBC 2009, it was stated that the opinion remains divided as to whether this should be part of the standard approach, and we have to wait until 2016 to get this consensus. POT should be considered a standard step in bifurcation treatment. The stent used in this registry was the Ultimaster. As you can see, it's a very well-known platform with specific features regarding the compatibility with bifurcation lesion, regarding the access to side branch, and capability for overexpansion in the proximal part. In this registry, 4,395 patients have been treated on bifurcation. The primary endpoint is target lesion failure at 1 year. All the clinical events have been adjudicated by the independent committee. The rate of clinical follow-up is good. And we here analyze the result by using POT versus no POT and kissing versus no kissing. In order to adjust the baseline characteristics and the lesion characteristics, and also the role of bifurcation technique, we perform a propensity match analysis. Very classical baseline characteristic for this group of patients. As you can see, it was mainly radial access registry, 12% of left main, 2 branches treated in 52%, and 2 branches stented in 24%. True bifurcation is 54%. The technique was, as said, mainly a single stenting. POT was used in 34%. Just to remind you the situation of POT at the time of enrollment in terms of recommendation. And kissing balloon was 36%. When two-stent technique was used, it was mainly T-stenting or TAP, followed by crush and culotte. POT is very beneficial, as you can see, no impact on cardiac death, but all other events have been reduced. TVMI, clinically driven TLR or TVR, and consequently the TLF is reduced from 6 to 4%, and there is also an impact on stent thrombosis reduction. If we consider the time domain, you can see that the divergence between these two curves occur very early and still continue along the time to 1 year. You can see that the benefit of POT is very consistent across the different subgroups, considering the location of the bifurcation, the diameters, the technique which is used to prepare or to post-dilate the stent, as well as the presence or absence of DPT at 1 year. When we analyze the predictive factors of 1 year TLF by multivariate logistic regression, we can see that POT is the only one regarding the technical approach, no effect of KBT. All other predictive factors are related to the clinical situation, the age, renal impairment, previous PCI, history of myocardial infarction, and the number of lesions. The story for KBT is a bit different, and we have two types of interaction. One is with DPT, meaning when you have DPT at 1 year, absence of KBT is related to a higher risk. And when you have a true bifurcation, the absence of KBT also is related to higher risk. Do we have any synergy between POT and KBT? It's not so clear. We have here a distribution of patients having POT and KBT, POT with no KBT, no POT and KBT on none of them. You can see that we have progressive increase in terms of target LMI on clinically driven TLR. We have significant values for the difference for these 2 points, and also a slight interaction with stent thrombosis. But of course, it's difficult to demonstrate this synergy considering the extremely low rate of events we have in the group of patients having POT and KBT. So to conclude, POT is clearly beneficial in all bifurcation lesions, whatever the stenting technique. KBT is definitely not a substitute for POT. There is no interaction between POT and KBT, but maybe there is a synergy. It's possible, but it's difficult to establish considering the low event rates we observe when we have performed both POT and kissing balloon technique. I thank you for your attention.
Well, thank you very much, Bernard. I think this is very strong data, despite it's not randomized, but it's the numbers are very important. I'm sure that you will have some questions. Yes, Patrick.
Very nice because it's big numbers and it tells us something. The question I have, if I look at the cumulative curve for event, yeah, you showed that, it seems that it's very early that there is something. I mean, I'm sure that if you do a landmark analysis at 1 month, for instance, the two curves will be probably quite superimposed. So what is making so much the difference in the first 30 days?
I think it's effectively right. Most of the difference occurring during the first month, and it's a combination of MI interaction with TLR and some stent thrombosis leading to urgent revascularizations.
Because that's an important message, that POT help probably specifically in that field and somewhat less for late event. Or is that the wrong interpretation?
No, it's not the wrong one. Effectively, we have to perform a kind of landmark analysis, as you suggest, after 1 month to see if we can observe something. It seems that the curve continue a little bit to diverge, but it's very difficult to say without a landmark analysis.
Okay, so everybody is convinced
that
POT is so important when you treat bifurcation lesion. Okay, so now we move to Milan Milasinovic, who will explain in the bench why POT is very important as a technical approach.
Yeah, Chairman, Dr. Lefevre, thank you very much for the kind invitation to the EBC meeting, and also thank you to Terumo for sponsoring this session. The presentation title for today will be POT in the bench model with Ultimaster Tansei stent. So my job today will be to illuminate the fact, as we have previously seen, that POT can improve clinical outcomes. Now, the straightforward answer to that would be that POT corrects underexpansion in the proximal segment of the bifurcation. And what I would try to deal with on the bench model is how POT facilitates side branch access, so how it can help procedurally if side branch intervention is needed. First of all, when we talk about POT, it is not only the proximal optimization we talk about, it is a technique. And a technique, it needs to be learned and executed correctly. So the emphasis of this brief presentation will be on how to correctly execute proximal optimization. And thereby, I would like to focus on 2 important segments. Not to overlook the proximal edge of the stent, and secondly, how to be precise at the point of the confluence at the bifurcation core. So let us first start with the more proximal segment. If you do not perform POT at all. What is naturally going to be happening, and you see it here on the bench, and thank you to Dr. Lefevre for performing meticulously this bench testing, what you namely see is that you can rewire abluminally. So you basically go behind the struts and you proceed then into the stent lumen without noticing this on most occasions on the angiography. And that is the great value of this bench testing, because it shows us that not seeing this on angiography has dramatic procedural consequences. So not performing POT leaves you with malapposition and under expansion, and the malapposition that you have in the very proximal edge of the stent can lead to abluminal rewiring. To avoid this or to circumvent this, you can perform POT and all is good. However, POT, being a technique, needs to be performed correctly, and if you perform it like this, as you could see on this example, it is too distal. So performing it too distal or with an undersized balloon leaves you at the proximal edge of the stent with the very same result as not performing POT at all. What you see now here on this bench test is that the wire doesn't go straight forward into the stent lumen. It rather still can go behind the struts, and you can still have abluminal rewiring, even though you think that you have performed POT. It was not performed correctly, and it leaves the proximal part of the stent still not expanded well with a large portion of malapposition. So if you think in terms of graphically depicting what we just saw, on the left-hand side of the slide, you see no POT at all, and on the right-hand side of the slide, you see inadequate POT with too distal and or undersized balloon. The consequence is the same. You can rewire abluminally. Now let us focus on the more distal segment at the bifurcation core. So if you do not perform POT, or if it is performed in a way that is not correct, you will practically always aim for the proximal cell when trying to rewire the side branch, as you can see nicely here in this bench test. This is not what we try to achieve with crossover stenting. We try to go as distal as possible when re-accessing the side branch. So how can we correct this? How can we give us a chance of distal side branch access? Well, by performing proper POT. And as you can see on this bench test, this may require 2 balloon inflations. So we need to take care of the proximal edge of the stent, and we need to be precise at the carina, which you now see after performing optimal POT. The wire still preferably goes through the proximal cell. However, we gave ourselves the chance of rewiring through the distal part, as you can see now. So once again, performing POT requires meticulous proceeding, and it may require more than 1 inflation. It is just important for us to know what are we doing. We need to be precise at the proximal edge, but we also need to be precise at the distal edge of the bifurcation core, basically. Only then can we allow ourselves the opportunity to have distal side branch access, which is for us important, as you see nicely here on this bench test. So you can always argue, or some colleagues argue, well, if we perform POT too distally, the consequences are carina shift, and carina shift may go away in a few days. Well, that is not always the case, and you see here in top, if we perform too distal POT as depicted here, what is the consequence? The consequence is unintended crush. You see here the nice near carina of correct top, and this is what happens if you do what was just done on the previous slide. This can, of course, translate to stent-related events. In conclusion, proximal optimization requires meticulous technique, and it requires knowledge how to perform POT, not forgetting the proximal edge of the stent and being also precise at the distal part at the bifurcation core. Thank you very much once again.
Thank you very much, Milan. It was really a great demonstration. I'm sure that there will be some question.
Gabor was suggesting there may be something on on the chat, actually,
Yeah,
which
Thierry.
will expand the discussion.
Okay.
Yeah, there was one question to the previous talk saying that pot plus kissing versus non-pot plus non-kissing. So everything versus nothing. Which one is better?
So it's a question for Bernard, I think.
Yeah.
But why not doing both? Pot and kiss.
Well, you see, so I think so I think Dejan is absolutely right that the technique is key and that we have to be clear. But actually, the risk of the pot going wrong is less probably than the risk of the kissing balloon going wrong, which might be why we see so beautifully on the e-ULTIMASTER registry a clear benefit with pot, which may be more consistently applied, where the final kissing balloon, we have every chance of putting wires in all sorts of places and distorting the anatomy much more dramatically, is my interpretation of where we see clinical benefit with one bit of the technique versus the other. So although Bernard's, I'm sure, going to answer, I wonder actually whether the final kissing balloon in the absence of imaging may cause more harm than good in some cases.
Yes, I think it's difficult to analyze the subgroup of subgroups, but clearly the combination of both seems to provide with a better result. What is sure that there is no real drawback to do pot, except if you do it too distally, as it was just mentioned. But there is a drawback to the kissing, particularly when the lesion is not so tight at the side branch level. You can create dissection and engage the procedure. It's something which is much more complex with double stenting. So clearly, this is the main difference between the two techniques.
And Bernard, if I'm not wrong, in the study, the subgroup of patients who had two stents benefit from the final kiss.
True bifurcation, yes.
So, Thierry, just the last bench testing illustrated very clearly about how to optimize the pot. And we have in the EPC, the pot is a very strong point to do in every bifurcation. For a TAP, I just wonder how strong do I have this recommendation? Absolutely, we will do a first pot, but usually if I do then a protruding stent, I will just end up with the kissing and no pot anymore. So maybe that was just an interesting thing in the bench we just said, but I would like to hear your opinion on that. The pot after a tap, I think that is indeed bringing us risks we potentially should not do.
So Milan, you have showed an example of internal crush with a pot after tap. Can you answer to this question?
Yes, thank you. So what we actually beautifully saw was that what you achieve if you perform the pot in the same way that we would do with the crossover stenting with TAP, you're going to have an unintended crush. And you basically have a nice lumen in the main vessel, but the lumen in the side branch doesn't look very nice. So this is something we do not want to have. So I don't think that we can recommend the same sort of a pot when performing a TAP as what we have with the crossover stenting. I think that if final pot is ever performed with TAP, it needs to be with a shorter balloon, and we need to be very well aware that we can distort the carina. However, the problem is that on angiography, you can never be sure how long the carina is. And if there is really a short segment that is stented above the level of bifurcation, I would avoid any sort of pot at all, because I think that's a clear, you are then clear, more clear in a way that you're not going to distort things, because what you're going to gain is not certain, because you have already performed a pot after first stent, for example, in the top, and then you performed kissing as well. So, and if the kissing is performed correctly without a long overlap, you are not going to have a large distortion of the proximal part of the stent, I think. So I think that we are running more danger and more risk in performing final pot with TAP than if we omit it, especially if we are unsure where the carina is, where the neocarina is.
Thank you very much. Patrick, you have a comment.
Yeah, I mean, for a few months, we had access with Evelyn Regard to OCT in the balloon. You could move the OCT within the balloon. It was fabulous. You could watch the recoil, you could watch the expansion, you could measure. I think if the industry was reintroducing an OCT in balloon, for instance, to do the pot, I mean, it would be a fabulous development. It's amazing that it was there, we publish on it, and it disappeared, okay? because initially that was the only way to get an OCT is to do from the balloon, okay? It took a long time to realize that by flushing and getting fast, you could get an image. But I think that we should ask these people to reintroduce OCT in the balloon.
Yeah, I think it's a very interesting approach to understand what we are doing.
I just want to make a short comment for the final. The final inflation and the final pot. I mean, the final pot is, I think, confusing because people then think it's the same as the pot, whereas final inflation, which is the bench paper we had done initially, was called final inflation proximally. And it was not called pot because the balloon doesn't go into the bifurcation. It's only proximal to the bifurcation. And I think it's the term final pot that is creating a bit of confusion because maybe it should be called final proximal inflation or final inflation. I mean, but final pot, it's not the same positioning, so it's definitely confusing.
I fully agree with that. So
If
maybe
I
we
may
have to find some new words from the proximal optimization after kissing by inflation.
If I may make a comment on this, and I think it's a very good point from Nicola and also from Dejan, because even if you position your balloon more proximal, as we discussed it yesterday, this conical tip of the balloon, it extends far beyond the marker. So even if you are very careful and you position your marker proximal to the carina, this conus tip of the balloon, especially in case of large proximal main branch, it will hit somewhere the protruding stent from the side branch. So I tend much more not to do it at all than to try to do it somehow carefully, hoping that it does not reach the no carina. So this means I fully agree what Tom said, that probably it's better not to do it at all than try to be somehow precise.
Okay, thank you very much, Gabor. We have to move to the next lecture by Tom. We'll show an example of treatment of bifurcation and the role of POT during the procedure.
Dear Chairman, thank you for the kind invitation to present at EBC 2021 and to Terumo for my involvement in this symposium, Mastering POT with Ultimaster. I've been asked to provide a clinical case discussion. So let's see, a 56-year-old male, in fact a medical colleague, which made decision-making slightly more fraught, presented with non-ST elevation acute coronary syndrome, preserved LV function, was found to have this significant proximal LAD lesion extending back to the left main stem. We see on multiple projections this severe disease within the proximal LAD, and this then leads to a question of whether you would nail the ostium, stent left main to LAD, consider a Lima graft, or image to then decide. And this was a polling that I placed on Twitter prior to presenting this case last year at an Indian symposium. In fact, half of those respondents suggested imaging first, perhaps partly led by the fact that I was asking the question. But we see that, some of the correspondents were suggesting nailing an ostium is unpredictable, that we certainly know that imaging studies help in terms of delineating where disease extends. Going straight to a stent, Peter O'Kane would suggest, is unnecessary, that you have to consider the imaging. Simon Ecclesall suggesting that we should be considering drug-eluting balloon. So I went about imaging without predilatation, so the quality of this run is not perfect, but actually it answers the question that I required, which is that we see disease extending back into the ostium of the left main. So we see the left main is about 4.5 lumenly. We see plaque at the ostium of the LAD. We see plaque at the ostium of the circumflex. And that very much fits with the IVUS consensus led by Gary Mintz, which showed beautifully that despite the Medina classification, that by imaging, we see that 2/3 of cases have disease that affect all three limbs. So I put out a second poll. Now we've imaged, what are we going to do? Well, there actually then was a relative split between nailing the ostium, regardless of the fact that there was disease extending to the distal left main, or stenting left main to LAD. Now, actually, the most contemporary EBC consensus would probably lean towards a crossover stent left main to LAD strategy, which was in fact what I selected. So having pre-dilated now with a 3-ONC, we get much better appreciation of the burden of disease. I've committed to the left main, so we see extensive injury. And in fact, you see now coming back into the left main that there is actually a relative absence of dissection at the moment extending into the left main stem. But select a 38mm stent, which can be 3.5 distally, but is going to need to expand to 4.5 proximally. And it's critically important we select a device that can appropriately expand. Now, the Ultimaster Tansei absolutely has that capacity. It's a very open cell design. It offers very uniform scaffolding, and it purposefully has just an abluminal coating for delivery of the sirolimus drug. And most importantly, as I've already suggested, this 3.5 platform will, on bench, expand to 5.8, as shown by Nicholas Foyn's group. So I place a 3.5/38 Ultimaster Tansei, placing in multiple projections. I undertake an OCT at this point actually just to accentuate the issue of this pre-pot under expansion of the stent. And we see beautifully here towards the polygon of confluence how massively under expanded that stent is within the left main segment. So it's then important to undertake the pot, and there's always discussion about where to go. And again, this was another polling for the purpose of an educational presentation, which is less easy to do in this virtual world, unfortunately. But I hope you'd all agree that position D is probably preferential in terms of placing it onto the carina, so a distal placement to enhance that apposition and open up the cells to recross into the circumflex. At this point, the OCT is used to confirm a cross of the wire, which actually was quite challenging in this example, and took multiple passes, and I never quite got as distal a cross as I was hoping to achieve. But ultimately, accepting the passage that I achieved, I undertook a 4.5 by 2.75 kissing inflation to clear the struts across the circumflex, and then went on actually, but due to pinching of the diagonal branch you can see in that cranial projection, to also kiss into the diagonal, again making use of this Tansei technology, which is advantageous in bifurcation. And ultimately achieved an MSA in the LAD of 7.2mm squared, and in the left main of 16mm squared, that really will offer the patient an excellent long-term outcome. And we see here from distal to proximal the difference made by the pot and then actually the kissing in terms of the stent coverage and the level of the polygon. So the learning, I think, from this clinical case is that there is controversy actually with a Medina 010 type anatomy. The consensus does lean towards crossover, and I've shown a nice example of where that can be efficacious. POT is absolutely mandated in bifurcation PCI, and I think stent design does play an important part in achieving good results for our patients, alongside the use of guidance by imaging to assure ourselves that we can achieve the best possible result. I thank you for your attention.
Thank you very much, Tom, for this excellent learning case. So do we have comment about this case?
Great presentation, Tom. I wondered, did you do a final? Did you do kissing in the circ?
Yeah, absolutely. Yes.
Yeah, I just didn't see that. You did kissing and then pot after that.
Yeah. That's. I may not have potted after that. Actually, it was just a kiss. Sometimes question whether it's absolutely necessary, but we've seen evidence of kind of tissue encroachment across struts that do sit across the ostium, particularly of the circumflex. So I tend in 95% of my cases probably to proceed to kiss. Really only if there's difficulty in terms of passage of devices around a particularly angulated circumflex would I probably avoid it.
Yanis.
Yeah, Tom, beautiful case, very nice illustration of how we can get along of 0-1-0 with like a single stent technique. I think two things. First of all, according to our recent consensus, we say that unless there is an angulation in the left main of more than 70 degrees, or there is a small rim to land the stent in the ostium, otherwise, less than 70 degrees angulation or no rim to land the stent, we prefer to extend to the left main, and you did correctly here. My comment is the following. As you show in your last, after the kiss, OCT frame in the distal left main, you changed the shape from cylindrical to oval. And I'm concerned whether that's optimal. In other words, don't you think we still miss the final post-dilatation to make it more circular?
Well, I think that probably brings us back to some discussion that was had prior to lunch, Yanis. I think it's a fair comment, but as Robert Jan mentioned, there's an asymmetry to the way that we take the imaging slices, particularly at the level of that bifurcation, just proximal to the carina. So I think that the purpose of highlighting that image was that it showed how beautifully we have stent coverage around every aspect of the bifurcation at that point. But I think you'd have to, at that point, take into account the fact that you've got divergence of two cylinders. And so I don't think that's a true representation of eccentricity. That in many ways returns to my naive comments about the polygon of confluence, which I now understand is a kind of arbitrary dimension made by QCA rather than it being a true anatomical space. But I think that makes for interesting debate around how you analyze and how clinically you assure yourself that you've got the best possible result in terms of returning the vessel to its true geometry.
Gents.
It was really an excellent case, and now the discussion actually opens again to the discussion we had just before about the T and the tap and the pot. And if you go back to the original idea, it was just that we do the pot to have access to the side branch and take care of the carina. Then we do whatever technique we would like to, and then we do the final pot, partly to correct for the oval shape, respect anatomy, but mostly to be sure that we have corrected the proximal part of the stent, taking care of the potential bottleneck or the foreshortening or the forlengthening that happens during the kiss. We can, of course, compensate a bit with the kiss, with a small protrusion and minimal kisses. But coming back to the rule of thumb that we made when we had the discussion, it was that the first pot take care of the carina and the second on the top of the bottle, the potential bottleneck. And then just the last comment about that circular thing we call the polygon of confluence. Whatever it is, this is the area in a bifurcating stent where the stent distortion is by far the most. And this is the area where we actually need to have proper ways of evaluating what is going on in that area, because this is actually the core bifurcation.
Thank you very much, gents. Any more questions? Okay, so I think we had a very interesting session. I hope that everybody is convinced that POT is crucial when you are treating bifurcation lesion. Whatever the technique, it's true. And Yanis, you have shown that in the virtual bench, that it's true for all techniques. You have to do POT if you want to optimize the result at the end. So thank you very much.